Welcome to this Nursing Times webinar looking at deconditioning and why it should be considered an avoidable harm. My name's Eileen Shepherd and I'm Senior Clinical Editor at Nursing Times. We have evidence that suggests that patients can spend up to 83% of their time in hospital beds, and that includes even those who are more able to get up and walk around. And for every 10 days spent in hospitals, our patients who are aged over 80 can expect to lose up to 10% of their muscle mass. And this has a considerable effect on them, causing deconditioning. And for many, this may be a tipping point from which they never fully recover. Nurses therefore have a fundamental role in recognising this risk and managing it. So the aim of our webinar today is to explore the benefits to patients of physical, cognitive and social activity, and the perceived barriers, including the availability of staff, access to appropriate equipment, and also the lack of appropriate skills and knowledge that sometimes occur in ward teams. We're delighted to work with our educational partners, Hillrom, who have provided an educational grant to support our webinar today. Thank you to Hillrom. At the end of our session, panel discussion, there'll be an opportunity to ask questions. So please post any questions that you have for the panelists in the chat box. So it's a pleasure to welcome our guest speaker, Anne-Marie Riley, who will explain why deconditioning should be viewed as an avoidable harm. Anne-Marie is Chief Nurse at the University Hospitals of North Midlands and has campaigned widely to raise awareness of the effects of deconditioning through the End PJ Paralysis campaign. So it's over to you, Anne-Marie.
Thanks, Eileen. So my name's Anne-Marie Riley and I'm Chief Nurse at University Hospital of North Midlands. And during this session, I'm going to highlight the potential harm caused by deconditioning and pose some questions that will hopefully help you reflect on practice wherever you work. Next slide. So there's a plethora of evidence highlighting the harm caused by deconditioning, and most of it has been around for decades. It can affect almost every aspect of your bodily function and can start within hours of admission to hospital. For some people, that harm will range from a delay in recovery right through to life-changing effects. The evidence suggests that you're more likely to develop a disability in your activities of daily living if you're admitted to hospital. And a contributing factor to that might be the amount of time that people spend immobile while they are in hospital, with a 83% of time being spent in bed. And whilst the evidence is heavily weighted to older people, actually the truth is the same of younger patients who are usually active. For a significant proportion of people, there'll be no medical reason why somebody needs to stay in bed or to have reduced activity. And that effect can be hidden almost. So it'd be interesting for people to reflect on how often do people discuss that type of immobility on their huddles or board rounds. Is it something that is discussed and noticed? Because the impact to patients of not being active can be quite significant, and it isn't that obvious to me that we as an MDT discuss it in the huddles as a harm event potentially, rather than the various different professional groups picking it up in their various pieces of work. So this next slide, can we have the next slide please? The next slide just highlights further some of the impact that deconditioning can have on those that we care for, and the potential long-term effect it has on a person, including loss of ability and their ability to recover. And these are just snippets from research that I've shared over the years, really. And again, a question back to the audience is just how curious your team or your organisation is to understand if this is commonplace where you work. So I'll give two examples. So one is a piece of work that I led in a previous organisation, and one that was shared with me via Twitter. So the slide that highlights that 50% of older people can become incontinent within 24 hours of a hospital admission I have to say, when I saw that piece of evidence, I didn't quite believe it could be true where I worked. So we did an investigative piece of work with patients and specialist nursing teams on a cohort of patients that were known to specialist continence advisors. And actually, unfortunately, the results weren't too dissimilar. So very quickly after admission, patients were using bottles, bedpans, commodes, or in some cases pads. And we, through our work, did know, so we could have prevented some of that, and that was disappointing to think that that was happening in our organisation. It did lead to looking at the other pieces of evidence to see if it was commonplace where we worked as well. And the piece of evidence that suggests how long people stay in bed, a consultant contacted me who worked in Wales, and his older persons ward did a piece of work where their patients had Fitbits on from a Friday right through to a Monday morning, and they monitor their activity over that weekend, and it just about made an average of double figures, which is shocking. I mean, it does show that the evidence is being seen in places that we work, and for it to get an average of just about double figures means that some people hardly moved at all. In fact, quite a lot of people didn't move at all, and others did minimal steps, which suggested probably we're going to a commode or a chair, but not really were moving much further than that. So I think a plea would be just, one, be aware of the evidence, but be curious. Is this type of thing happening where you work? And if it is, are you feeling empowered to start some discussions about why? Because when we start asking some of the reasons why, we can start to think, what do we need to do in terms of pieces of work to understand what root causes there are, and the right actions to try and prevent some of this. So the next question relates to this scenario. This is a made-up scenario, relates to an older person who I've called Fred. He lives alone. His wife died not a few months ago. He's got children, but they don't live with him. And whilst he's not getting out and about as much as he did, he is independent at home. He had a fall, which left him with a painful hip and bruising to his face. And he was admitted to hospital on a Friday night. By the time he gets through our admission process, it's quite late by the time he gets into a bed. He has a small amount of physio on the Saturday, but nobody really notices that Fred is in bed really from Friday right through till Monday. By the time he gets to Monday, he's really struggling to mobilise, and it isn't in a state really where people feel he's safe to return home, and needs some supportive rehab before that time. For Fred, this is devastating. He wanted to go home. That's where he raised his family, where him and his wife lived happily, and the fact that he can't go home massively affects Fred. And ultimately, although he goes on to have, he gets discharged from hospital and he goes to a rehab facility, he doesn't ever go home. And my question is, do you think we harmed him? If you look at what we would look in terms of measures, his risk assessments were all completed. He had compassionate care, and he was happy with the care that he was provided with. He didn't have a fall in terms of a pressure ulcer or a fall, and he has a safe discharge. So on the face of it, he looks like he hasn't had harm during his care, but actually he does have deconditioning harm when you look at the evidence. He doesn't walk for 3 days, he doesn't use the toilet, and he loses continence function. Although he is eating, he does lose a bit of weight, and he doesn't go back to his usual residence. Now, if Fred had fallen, even if he came to no harm, we would do a risk cause analysis into that and understand what we could have done differently to prevent that happening. But we don't report the type of harm that Fred had. He deconditions, and there isn't very many organisations that report deconditioning harm. I started implementing that whilst in a different organisation at that time, which was less than 2 years ago. I find another organisation. So a lot of the type of harm that Fred had is hidden harm, because it's not something that we report routinely, and therefore can we say that we've learned from it? So my question would be, do you report harm in your organisation? Would you recognise this type of harm where you work? And if you don't, do you think we should? Because having no visibility of it means that we can't do the right actions to prevent this harm happening, and it affects the types of policies, procedures and the way we work. So if we haven't got sight of it, actually we're not working in the way we might need to be. So next slide. So my next question that I'm posing is whether some of the terminology that we use support staff to focus on the right actions. And my example is falls prevention. So if you look at the way that we use the term and the types of targets and actions that we do, the aim is that we stop people falling. I mean, quite rightly, that we stop people falling. But what we don't do necessarily is celebrate when people do the right thing, but their target doesn't hit the mark. So if you have somebody who we want to see mobilising, and in the mechanism of keeping them active and supporting their rehab, they're lower to the floor, which is registered as a fall, a number of times. Would we focus on the success of that? That if this was Fred, we kept him active, we maintained his muscle strength, he got home, or would we look at the negative, that the falls on your ward were high? And I would say probably the latter, unfortunately. So I think some of this, a subtle change in word, you might want to drive the right targets, but drive the right behaviour. So in this case, would supporting safe mobility be a better phrase to use than falls prevention? And that would apply to a number of the activities of daily living, where a subtle change in terminology would mean that we change the outcomes that we look at and the actions that we drive. So my last point is about how do we measure success. So if you look at this chart, what assurance does it give you in relation to deconditioning and mobility? And if we're not measuring any of the other measures relating to deconditioning, then I'd argue it can't really offer you very much assurance at all, given that we know that patients can spend very little of their time actually walking about, and it's quite easy to lower your falls rate if people don't move. So I think the challenge for us all is, are we looking at these indicators with the breadth of information that we need to make the right decisions and drive the right actions? So if we go back to Fred, and we drove the right actions, as in we kept him mobile, and unfortunately he was lower to the floor, he didn't come to any harm, that chart might not look like that. It might look like the falls going up, but what we would hopefully be able to measure that with, if we drove the right behaviours and with the right targets, is a suite of metrics that balance the view, that said, yes, the falls might look high, but actually we've got measures relating to loss of functional ability, which shows actually patients are losing less of their function while they're with us. They're not losing weight, they're not losing continence function, and they're getting back to their place where they want to get back to. So we've got a triangulated view of harm and outcomes, whereas what we tend to have are metrics like falls, and we make judgments based on that, and I don't believe we've got quite the right suite of metrics. So it'd be interesting when you do your own reflection, is that a similar way you work? And if it is, what can we all do to try and change this so that we've got up-to-date, relevant metrics, rather than what sometimes we've had traditionally, and they might not be the right ones anymore. The final point would be ask why. So when your patients are coming into hospital and we do the assessment to say, this is what Fred was like at home, and he was active and he was independent. When people aren't like that in our care, ask why. At the MDT huddle, at your board round, just so that we're focused on why these changes are happening and if there's anything we can do to stop them. Now, some of that might be related to somebody's condition, and that's fine. We've asked the question and we understand why. some of that might be that we, because of resources or pressures operationally, that we can't provide the right care to prevent some of this happening. And my plea would be is that we start highlighting that through reporting, so that we can flag it right through the organisation to highlight that this harm is happening and we don't have a countermeasure to prevent it, rather than we accept we can't do something because it's operational pressures. So my plea would be, whether that's staffing, whether it's ops pressure, whatever it might be, highlight it, because then we can start to have some really good conversations, and the right conversations at the right level to think what we need to do differently. So I hope I've given you some food for thought and supported some reflection on practice, and some of this will drive some different behaviours where you work if that's what's required. So I just want to say thank you for listening, and I hope to be able to see some measured conversations and some discussions as we move through the sessions. So thank you.
And thank you very much, Anne-Marie, for that really, really comprehensive overview in 15 minutes. That was unbelievable. And you've given us lots of food for thought there. Thank you for joining our panel discussion now. We've got lots of questions coming in already. And I'd like to introduce our two other members of the panel. We've got Julie Windsor with us. Julie, would you like to introduce yourself?
Certainly. Thank you, Eileen, and thanks, Anne-Marie. That was great and really interesting. So I'm Julie Windsor. I'm an RN by background, and I work currently for the National Patient Safety Team in NHS England and Improvements, and I'm the lead for medical specialties and older people. Some of you may know me from my other clinical expertise in falls prevention. I've been around on the falls prevention side of things for many long decades now, and I have some expertise in that area, so I'm wearing both hats today. So thank you for inviting me.
Thank you. And Sharon, could you introduce yourself?
Can you hear me? Good.
Yeah.
Hi, my name is Sharon Rinsland. Well done. That was really, really interesting, Anne-Marie, really interesting. I'm Sharon Rinsland. I'm the Moving and Handling Senior Coordinator for East Kent Hospitals. Background radiography, but my main focus, my main goal is actually about mobilisation and the importance of mobilisation and getting these patients moving. And I very, very strongly believe that manual handling can become very disjointed with regards to where it needs to focus. So patient along with staff safety to keep these patients moving. So I'm really, really pleased to be invited here today. Thank you.
Thanks very much, Sharon. If I could start our discussion, Anne-Marie, picking up on your presentation, I was really interested in that idea of curiosity. And it just made me think about nursing models and how in nursing a fundamental part of care is activity, mobility, looking after people's cognitive state, and stimulating that. And I'm curious as to why you think those aspects of care have almost fallen down the list of priorities. Why is this a particular issue, or has it always been?
I don't know if it's fallen down the list of priorities. I think there is, having done quite a few talks up and down the country over the years of being involved with MPJ paralysis, I think it's not that people aren't aware of much of what can happen to people. I think they are. I think sometimes it can be a surprise how quickly it can happen. You know, from a Friday to a Monday doesn't seem that long, and actually you can do the damage, some permanent damage in that time. So sometimes there's been a view that the speed of the decline and how long it can take somebody to recover, if they recover at all, maybe wasn't quite as well known. I think there's no doubt it is incredibly pressured. It's been pressured obviously through COVID, but for some time before that as well. You know, we've had staffing issues for years, haven't we? And so I think in the busyness of trying to get things done on a shift, I don't believe it's intentional. I think it's just people being very busy. The one thing that did get fed back when we were doing these sessions in various venues was people were very frightened of people falling and what that meant in terms of a target. And that's what prompted the discussion around that in particular, because we shouldn't be frightened. We should never stop somebody walking because we believe it misses a target, because we've completely missed the point, haven't we?
Absolutely.
So I think there are some things, but that isn't the fault of clinical staff. I think that's for us in senior roles to be considering the standard we set and the things that we put in place that encourages people and supports them to do what is right for patients and not be worried about the target almost.
Yeah,
I wonder if I could jump in there, Anne-Marie. I think you raise you know, a very pertinent point there, that and I just sort of like put the balance between falls and patient safety. So I've been around in this field for 20-something years now, and I would say that the patient safety label for falls was some of the best things that ever happened to falls, and some of the worst. I mean, in terms of some of the best, in terms it got it up on the agenda, whereas previously we have been completely off the agenda. The downside was that the target-driven monsters grabbed hold of all of this and started applying all of those target-driven pressures, which in the falls world, I would say we're not that bothered about the targets. A very old and dear colleague of mine says you can't fatten a pig by weighing it, which, you know, and you can't reduce falls by counting them. You've got it's the interventions, and I think that's what we're all saying here, and I think that's the bit that we need to hold on to. I think there is a leadership responsibility here, and I mean in terms of all of us with leadership responsibilities, to support organisations and staff members individually or in groups, to say, you know, a fall isn't necessarily the worst thing that's ever happened. I mean, they're going to happen, and nobody wants to be cared for in an organisation where you can't stick a leg out of bed to care for yourself. Falls prevention often gets blamed for the immobility stuff, and I would put a plea in there, because, and I would say, I know this because I'm the author of much of it, is that if you go back to the fall safe stuff, which is 10 years plus, and I'm just reviewing some of those e-learning modules as we speak, actually, that one of the first interventions is about deconditioning, prevention of deconditioning, because of the risk for, and I think one of your questioners has pointed out about the risks of postural instability because of muscle mass decrease and bone density, so the risk of fracture goes up as well. So our very much would be, give the person, if they usually use a walking aid, get one straight away within the first 24 hours. That's 101 of falls prevention. But somehow those messages, which are churned out again and again and again, don't land. Or if they do land with individual staff, the organisation is not supporting them to act. And I think it's those things that we really need to start to unpick now, about what is the leadership expectation, what are systems and processes in terms of actually getting the kit to the ward. So it's no good having all good intentions about giving the patient their frame if you haven't got any, and the physios won't release the funds to pay for them, or whatever your issues might be locally. Yes. So it's those sorts of things, I think, that need to be tackled in order to support staff to do the right thing that they want to do.
Yeah. Thank you, Julie. Sharon, it seems a good point to bring you in here to talk about equipment and access to equipment. Do you think this access to equipment and use of equipment is an issue in terms of getting people up and mobile? Sharon, you're on mute at the moment. Yeah, you're still on mute. Just while Sharon's just sorting out her sound problem, one of our questioners, Karen Davis, has asked, which links in with what you're talking about, people being risk averse. She asks, I wonder if acute staff are risk averse to enable patients to wander around the ward or area. falls, trips, slips, wandering away from the ward. So I think there's those two concerns she's balancing up, which you've just talked about. Anne-Marie, did you want to come in on that?
I think there probably is, and it is this fear of people falling, and I think we don't want people to fall and come to harm, absolutely not. But if we constantly tell people to sit down or lie down, one, that isn't any good for their mental health and well-being at all, but we are harming them in that process because we're stopping them. And it's similar for some of the mechanical mechanisms are out there to tell you somebody's moving. Actually, what they end up being is a way to tell you when somebody's moving, so you tell them to stop moving. And that's the bit that we've got to change, I think, and recognise that it's fine for people to walk about. And yes, we have to make them as safe as they possibly can. And we don't want anybody to come to harm, but stopping the moving isn't the answer.
Yeah, I would absolutely agree. And in preparation for today's session, I was talking to some falls specialist nurses in and around different localities, just to make sure I had my thinking still, on the pulse, if you like. And one of the things that we were talking about was that I don't know if the staff rotations happen like they used to. Maybe not. And there seemed to be a fear that they're thinking that there wasn't. So in old money, you used to go and do your time in rehab. You used to work with multidisciplinary members of staff. You used to pick up mobility, assessment and intervention skills. You used to see people moving. If you've only ever worked in an acute ward and ever only seen sick people, it's really difficult to visualise what those people can do. And therefore you think that people should be and are sick and should remain in bed. For those of us that have worked in other clinical areas, rehab and in day hospitals or in community settings, you see extremely sick and frail people every day doing the impossible. And unless you've been exposed to that as a clinician to know that that's okay, the terror that must cross your face when you see this elderly frail person launching themselves unsteadily across a wall with a frame. It's about the knowing, isn't it? The tacit knowledge, if you like, of acquiring that over a period of time. And I'm not sure we assist our staff to get to attain those skills now, for lots of different reasons.
Can you hear me now, guys?
Yes,
Sorry.
Sharon. So we'll come back to that question about availability of equipment and whether staff can get the equipment they need and do they have the skills to use it.
Yes, I'm just going to go back a little bit in time because I'm going to show my age now by many, many years doing the job that I do. If we think about manual handling as a whole, many years ago, manual handling, we were the equipment. We were taught techniques to physically move our patients, which deconditioned our patients rapidly because we lifted them up the bed, they didn't move themselves, we lifted them out of the chair. And if there was any piece of equipment that was devised, I remember this old-fashioned handling belt that came in, and it was a handling belt, but we used it to put underneath the patient's bottom, and we physically lifted them out of the chair, stuck them in a wheelchair. So if any of you out there remember that, you'll know exactly where I'm coming from. So with equipment, that's a lot about what we did as people, as manual handlers. And as we've moved forward, manual handling has changed massively because we've gone away from this. We are doing everything for the patient and the patient's got to do stuff for themselves, because we actually did decondition them very, very quickly for those reasons. Today, there is a lot of equipment out there that can get our patients moving quite quickly. And there's lots and lots of barriers to that as well. And the barriers are, one is that we are forever changing staff. And I do agree with our ladies that, because our staff are changing so rapidly, you change and you train them on a piece of equipment, they're gone, and then you've got to start again through the same process. So staff are less likely wanting to use the equipment for that reason, or we're changing specialities, so they're moving from one area to another. Where if we start to look at focusing back into specialist areas, we could then design equipment and keep equipment in those areas for those individuals who know everything about that individual patient. We did a lot of work many years ago where we started to make the wards specific. So we had medical, we had surgical, we had renal, which we've still got, yet
think we've lost Sharon there for a minute. So interestingly, Sharon's mentioned layout of wards there, and we have a question about that, which is, do we need to think about the layout of the ward to enable patients to move around more normally? Anne-Marie, could I bring you in there?
Yeah, so most people will know, if you've been in the NHS for a while, that the days of having day rooms and places for people to do, you know, to have a place to go to move around have long gone. There's not many of them. You know, Trust will have the odd room here and there, but they're not matter of course. There are other ways to set your ward out so that people can get together. When I was at Nottingham in trauma and orthopaedics, they put all the patients' tables together so they could eat together. They did activities, and really, really simple things that can make a big difference. So it can be done. Takes a bit of thinking, but the teams who work closest to those patients will have some really fantastic ideas. That's how we got ours. It was listening to people who worked with patients to say what's feasible in your area with your specialty. It's one, listening, and then supporting team to be able to do some of this work. Now COVID has made things a little bit difficult because we're not getting people together in the same way, but it will be gone. You know, at some point we'll get back to some level of normality, so that people can be thinking about what could be done differently for the days when we can start having people sitting together and that type of thing.
Absolutely agree, Anne-Marie. I was famous when I was clinically based for saying those things aren't nailed to the floor. I mean, in the tables, the chairs and the beds. And there's also something for me about we spend a lot of staff time on observations of patients. So even putting people in bays to observe patients. Well, in my view, they shouldn't be latent observers. These should be integral and engaging in therapeutic intervention, which would include getting up, moving around, introducing them to the next door neighbour, you know, in the next door bed if that's appropriate for them to do so, or maybe not in some cases. But I mean, you know, people who work there will know this, and it's about, I think, the leadership of the ward, of that unit, of that hospital, actually the expectation and a supporting staff that's what's required. That's what we want to see. So therefore staff get permission to do these things. I think staff would like to do these things very often, but feel that they can't in some ways, particularly staff. If you're an agency or bank or whatever, you don't know that ward and you think, well, I could be doing all sorts in here this afternoon with these 4 people, but I'm not sure if it's allowed or not, you know. Whereas I think it's about the messaging, isn't it, from the organisation to say it's okay, absolutely it's okay to do that. The other thing I wondered about, in terms of, just quickly to mention, because it really burning issue for me, is these 12-hour shifts. Is that a lot of organisations still have. Now, I know that if I were at the grand age that I am, I think I wouldn't survive a 12-hour shift, frankly. However, if I was staring down the barrel of 12 hours looking after 8 people or more, and I knew that I had to get all of them in and out of bed, on and off toilets, you do the maths, how many times of them moves is that over the course of the day? How keen would I be to do that? Or I might be a bit keener at one end of the day than the other, perhaps. And I think there's something there as well about staff fatigue and these addressing.
Thank you. I've got a question from Jill, which sort of links into some of the things we're talking about. And she says, is there a clash of perspectives between the medical model and the nursing model that throws up barriers to patients moving? And we've also had an interesting question about medical diagnosis and whether, that's right, in my ward, the nurses let the medical condition hijack the mobility care, i.e. patients are kept in bed because the patient is too sick rather than getting them out of bed. How would the panel handle this? So there's that medical model, and we talked about the nursing sort of perspective earlier on and shifts and things. Anne-Marie, could I ask you to take that one?
Yeah, so I think there is something about the paternalistic part of our professions where we, you know, people can't do something and we've determined they can't do it with very little good reason quite often. I remember hearing a talk from a really well-known chief nurse whose mother went into hospital, deconditioned and died. And the phrase that she used is that her mother was killed by kindness. So where people were doing things in all good faith for her mum, and so she didn't have to do it. But in that process, she deconditioned and she didn't recover and she didn't get home. And I think for me, that's why it's so important that we consider this as harm, because nobody wants to harm anybody, but we don't use the language. So the fact that somebody is in bed, you know, and we're doing it because they're resting, and not recognising all the, but they're doing this and this is happening, it doesn't give a very balanced view, I don't think. So unless we call it out for what it is, I'm not sure how much will change. As soon as we start calling it out for what it is, and we've got the right metrics and triangulation of data, we'll be able to support staff to do the right thing. Now, it is tricky. We know, you know, it's incredibly pressured everywhere. And even if we can't resolve every issue that areas have got, if we're flagging them up, you know, I want to be able to tell my board, this is what's happening. These are the risks that we've got. This is the mitigation we've tried. This is what's outstanding. And at the minute, if it's not known, we can't do that. So that's why I think it's really important we start talking about it. We've got to recognise we're doing it first.
Yeah, I agree.
I think there's, looking at some of the questions and thinking about what you're saying, I think there's another few factors, I think, as well that need sort of consideration is, and it goes back to your care planning point. So there's something about who does the care planning and who does the delivery, and do we skill up the appropriate staff at the appropriate level to deliver that care? Now, certainly, you know, support workers, you know, on the whole, do the majority of the the patient-facing staff. I think that's fair to say these days, and I'm not sure we're always very good at skilling them up to give them those skills about it is okay to get this person up, it is okay to sit them out, it is okay, you know. It's all very well writing it in a plan, but actually the delivery of it, I think, is we need to support staff to be able to do that, to acquire those bossy skills that you pick up in rehab, if you like. There's also, going back to the questioner's point about the medical nursing models, I personally don't very often see a culture clash there, and I think Falls is really helpful in as much as Falls prevention and intervention can only be multi-professional. If it's not multi-professional, you're not doing it right, frankly, and that's why probably half the problem. So I think it lends itself really, really well to have opening up those conversations between your support, you know, your supporting team to say, thinking, oh, I'm going to start getting Mrs. Miggins out of bed now for breakfast, who's against it and who's for it, sort of thing, and making sure that you're all on board with it, including Mrs. Miggins, of course.
Thank you. Thanks, Julie. I think we've got Sharon back with us now. And Sharon, I wanted to ask you a question, quite an interesting one, about litigation. James has commented, litigation is to blame. Whose fault is it? Who gets the blame? I wonder, in terms of moving and handling assessment, what your thoughts are on that. I thought Sharon was back with us, but
can you hear me now?
Oh, I can. Yeah.
Sorry for that. We for some reason we had a power failure and everything went off.
Oh,
that's typical, isn't it? So yes, in answer to your question of litigation, with any piece of equipment or anything that's brought in, or
I think we might have lost Sharon again. Julie, could I bring you in on that one?
Absolutely, yeah. So there's been a recent report some of you may have seen from NHS Resolution with regard falls in the emergency department, and because they did a deep dive piece of work. Don't ask me, I couldn't quote you any of the numbers associated with that, but in terms of faults, I think that, you know, there is no fault. I think it's wrong to view litigation as apportioning fault or blame, or even investigations. If you're apportioning blame in investigation, you are definitely doing it wrong. And I would say I put a bid in for the new patient safety incident response framework that's just about to come out, and we're working on some documentation, some support work. I'm working on that with the Royal College of Physicians about after action review and safety huddles as an alternative to investigations, because I think that, you know, we all know the current investigation system is not working for patients and it's not working for staff either. So this is, keep an eye out for that. But in terms of the NHS resolution work, I think there was no blame to be apportioned, and of course it won't ever come to the individual, because each organisation will have its own you know, insurance, if you like, and the NHS has its own insurance. So we should never apportion blame to the individual. So I think, yeah, if that's happening in your organisation, I think that needs to be a conversation had at the most senior level, I would say, and maybe, yeah, talk to your staff side support if that is the case.
Great, thank you. Thanks, Julie. Sharon, are you back with us?
Yeah, I've taken the headphones off and hopefully it was them that was mucking around. So hopefully you can hear me nice and clear. Yes, I do agree with everything that Julie's just said there. It is not about blame, but within manual handling itself, whatever it is we're doing, whatever we're teaching or whatever equipment we're bringing in, we should be assessing always. So every piece of equipment would be assessed and every member of staff using that equipment should be competent in its use. And if they're not, they shouldn't be using it. So it's there that we need to be careful, because for our argument's sake, if someone uses a piece of equipment they're then not trained on and the patient falls and could sustain an injury from that fall, or possibly even a death from that fall, we could then be looking at, and I've done a few cases in court with this, why did that happen? Now, was it something that was a contributing factor that was a trust problem, meaning this person was never put through their training, they never went through the proper processes, their policies were weak? Or was it purely that this person felt individually, I'm not going to attend training because I know best, I've done manual handling before and I know what it's about and I'm not going? Because you also see that. So we do have to take some responsibility there, because it can prove that it goes in that direction. It really does depend about the case itself and the circumstances. So majority of the time, not normally a portion of blame, but depending on the severity of injury and how that injury was caused would determine whether it was the person or was it circumstances.
Thank you. Thanks, Sharon. That's very clear. Does anybody else want to come in on that point?
I was just going to say, part of what we have to do is have really open, transparent conversations with patients and their families. So if we've developed a plan of care where mobility is part of that, because it needs to be, and we talk about the risks of doing that, but also show what the benefit might be and what the harm will happen if we don't do that right at the outset, and we're having those conversations, or we are going to let, you know, Fred walk around the ward, and we'll keep him as safe as we can, but it's really important that he does walk about. Actually, it might take some of the, you know, the one family's expectations that it's unrealistic to think you come in and nothing, if you fall at home and you do that safely, you know, you can go around your furniture and we can keep you doing the same in hospital where you walk around, you might need lowering to the floor, but we keep you safe and we protect you from a real harm. It's unrealistic to think that that person is suddenly going to be walking differently when they're in hospital. So the only way we'll stop them doing that is if we stop them walking. But we don't, it's whether we have the conversations. And I think that's an important part of it as well.
Thank you.
I think also a good point earlier on where we talked about, just as I got cut off, we were talking about deconditioning. We were talking about sort of like the medical conditions, or they've had a surgery and they're saying the doctor doesn't want them moved because they've had surgery. The thing about deconditioning, it can actually still be, you can actually move your muscles and you can mobilise whilst you're actually in bed. Just because you've been told that you have to stay in bed doesn't mean to say that you can't move your legs or your arms. So even little things, I know our physios work really, really hard and our OTs to try to get these patients moving, but sometimes when they're gone, that stops, and I think that's where things break down. So actually just popping a slide sheet underneath someone's foot and moving their legs backwards and forwards for maybe do 5 times to get that muscle working, you're still building up strength in the muscle and not just leaving it to the next day that the physio comes in. I fully appreciate our nurses are absolutely busy. We don't have enough of them. They're overworked and underpaid. We all know those stories, but the bigger picture here is because we don't have all those factors in place, that's why our patient deteriorates quite quickly and deconditions quite quickly, because the physio's been in, they've done what they need to do. They may not be back in till tomorrow, so that's 24 hours now. This patient has not moved. When the beds go into a full chair position, so it's not as if when you're getting them out and stick them in the chair, you can make that chair from the bed. So you're opening up their lungs, you're sitting them up properly, you're opening those airways. We've all seen that typical patient that's in a bed where the bed's not profiled properly, they've slid down the bed, chin in chest, airways closed, lungs, well, now on oxygen, when if they were sat right, possibly don't need it. So there's lots of things that we can do with equipment, whatever the equipment is, not necessarily having to move that person from that position.
Yeah. Thank you very much, Sharon.
I completely agree, Sharon, and picking up on your physiotherapy point, I think this is another big barrier I think that needs properly exploring at organisational level. Is there's lots of misinformation and misunderstanding that the only people that can move patients are therapists, and the only people that can give out walking aids are therapists. But nobody's asking a nurse to become a registered, a chartered physiotherapist overnight. But that's not what we're asking. There's a very big difference between therapeutic intervention by therapists to extend and improve and increase their whatever they're doing with the patient, and everyday mobility. They are completely different things. And as you rightly point out, Sharon, at best your therapist is going to see your patient once a day for maybe 30 minutes. What are you going to do for the other 23.5 hours, because you still need to move that patient? And it's about working together with your teams to make sure that you share those skills and there's understanding about whose responsibility it is to move the patient.
And that's where those disciplinary teams need to come in. So you're working with tissue viability, and you're working with infection control, and you're working with physios, and you're also working specific teams within that speciality. So that's why it's important to have specialist nurses in certain areas, and that's where you can then generally focus on what equipment's going into those areas, see what is needed, and every person's trained competently on the use of that equipment. So it's across the board. It's not just one person, it's a team of people doing the same thing. We will then see a massive difference in how our patients rehab and move forward.
Thank you, Sharon. This ties in with a question from Hayley. If I could ask you, Sharon, to follow up with this one. Do hospitals have mobilising patients and basic mobility assessments and provision for basic walking aids in nursing and healthcare support workers' competencies? So I think it's about the competencies of nurses and healthcare support workers to provide equipment.
Yeah, we do that. We have patient mobility assessments, whether they be general or whether it be a bariatric patient mobility assessment. In fact, I've just reviewed all of mine on the back of all the articles that I've written regards to around patient mobility, because it is a massive topic and a burning topic for me to make change. So I actually went back away from that after writing those articles and looked at my own patient mobility assessments, because I thought actually I was picking holes in my own work. And I could see, it just goes to show none of us are perfect, or where those problems were. So I reviewed all our patient mobility assessments, and then also reviewed the competencies and the training on the pieces of equipment that was going out there, and tried to simplify it so that the assessments and the competencies were all in picture formats now, so that people could see actually we all read very differently. We have different walks of life, different understandings with language barriers. So if it's pictures, it makes life easier, and videos. So we've now pushed that forward to try to push patient mobility. So an assessment is so important, because if the assessment's not completed, how does the next person coming in, who might not know this patient from Adam, and yes, we should be talking to that patient, of course, but sometimes patients are confused. They'll tell you they can get up and stand and run around, and yet they can't. And that's where we end up with fall, because we then got the patient out. So patient mobility assessment is so important, and it should always be scored personally with a red, amber and green scoring system, so we understand what it is we're looking at. We understand the severity of risk and what risk we're working towards.
Thank you, Sharon. We have a question, Anne-Marie, if I could pose this one to you. How can ancillary teams, domestics, patients, dining support workers. Aid to prevent deconditioning of patients to alleviate pressures from clinical teams.
I think that will vary in different hospitals depending on what they are and aren't allowed to do, if I'm being honest. My argument would be anybody who comes in contact with a patient's got an opportunity to have a positive impact on them. And different organisations need to understand the workforce in its entirety and the relationship to their patients, and then risk assess what what is right for that group of patients, and it will depend on specialties, as we know. But I think that's the best thing people can do, is just look at what does the patient need and who have we got in your teams that can give that patient the care that they need or the observation that they need. We talk a lot around blended workforces and using staff differently, and actually there's not masses of evidence that we've changed hugely. There's little bits of change, but we haven't really done it en masse. And I think as we're in this position where the vacancies are getting bigger, the challenges are getting harder, more of this I think will become evident. I think we'll be forced to do it, I think, to be able to think what can we do differently that means that patients get what they need, and it might not look the way we've always done it. And I think it's right if it's the right care at the right time for the patient.
Okay. Julie, did you want to come in there? Sorry, you're on mute, Julie.
Sorry, I was just saying I completely agree with everything you've just said, Anne-Marie. No, I've just read the next group of questions that have come up, and I'm thinking, oh, good questions.
Yeah, aren't they?
Okay.
I totally agree that I think that we are changing, and I think the way nursing is changing. And I often think about do you remember we used to get your helper by the bed that you still get, that used to feed your patient? And I think going forward, maybe that's something that we look at doing. That not, if that physio shows an arm lift and a leg lift, but our poor old nurses haven't got a chance to do that because they're running ragged, then having the helper to do an arm lift and a leg lift and that just tries to get them moving, or we need to be looking at costs of deconditioning, which like we said, Anne-Marie said earlier on, they're only coming to light now because people haven't recognised it. Costs of that, and then bringing more staff in that are actually going to move that patient forward, because it will actually outweigh those costs, the benefits of it, and using the right equipment, of course, as well. So
yeah. I think that there's an interesting question that sort of ties in with what we're talking about at the moment, and it's how can a student nurse appropriately assess someone's mobility, especially if the OT and physio are unable to get to them. Julie, did you want to take that?
Yeah, I could take that and the question above, actually, because they sort of link together, if you like. I'm happy to have a bash at that one. So in terms of what's out there to help you, I put a bit in again for the new and improved full safe training that I've just updated all the support and resources in it. Now, I don't know if you all know about this, but it's an e-learning module. It's full safe and care full, actually. So, but full safe is specifically for nurses in acute care. So it's a learning module with lots of videos and training, and it's all very whizzy. And it's available on Health Education England website. It was about to be again, and once we released it live. And in that, there are sections on there on how to do precisely that, what you've just asked. How do we assess people's mobility? How do you give them a stick? How do you give them a walking aid? And it demystifies it. Now, it's unfortunate because we filmed it 11 years ago, and it's unfortunate the only people willing to go on camera at that time were therapists. And if I had my time again, I would take them out of that blue and white and put them in something less distinctive, shall we say. It could be anyone. But the skills, they did not train for 3.5 years to give out walking aids. So these are really, really straightforward things that anybody can do with a minimum amount of training. So there's that resource that's coming back online again, and anybody can link into that. And there's the other way, if you can't wait for that, is something that just ask the therapist on the ward. If you've got a therapist on the ward and your student nurse is standing there, well, I'd like to have a crack at that, but I'm not quite sure where to start. Stick yourself to the physiotherapist for half an hour and watch what they do. They're magicians at moving patients. You can pick up so many skills.
So this misconception that you have to wait for the physio to get somebody out of bed, we really need to knock that on the head, don't we? And empower.
Yeah, no, I'd agree. I mean, that's notwithstanding, some individuals will need specialist movement, but if that is the case, then the physiotherapist 9 times out of 11 will have said that specifically. This patient, and the manual handling advisor has probably been in ahead of even the patient's admission, and certainly in the hospital I used to work at. If we knew that people were coming in with very, very specific handling requirements, we would know about it, you know. But the everyday, day to day, most everybody else, you don't need to be an expert. You just need to be competent.
There's a question in.
I'll bring Sharon in and then Anne-Marie. Sharon?
The only thing I wanted to say there as well, I think this is important, that it is about standardisation. You know, we've got so many acute trusts out there and we all work very, very differently. And so from one trust to another, you just learn something, you go somewhere else and you learn something else. So standardisation with everything that we're doing, we're trying to do that within manual handling and through our National Back Exchange to standardise a process. So that's right down to our student nurses. And I know down here in East Kent, we train our universities near us, so our student nurses coming through. You know, it doesn't always work as I'd like it to. You know, we're not perfect, but we'd like to think that we're teaching them the standards. So when they come into a hospital straight away, they know what they can, or have that support for being able to do what they need to do. Because there's nothing worse as a student nurse when you come in to feel, what can I or what can I not do? And that can actually put a lot of students off nursing.
Thank you. Anne-Marie, did you want to come in with the last point?
It was just, there was a comment in the chat around the bedside mobility assessment tool, and that must be from Warsaw, because they did a huge piece of work on that very thing about empowering the people who are with patients, most nurses, to be able to assess patients and get them moving. So they've said, do they want it to be shared? So I think the chat said yes, they'll share it if trusts haven't got anything, but it's really simple.
That's great, thank you very much. Yeah, I think if we've got resources, it's really good that we share them, and you know, and that point about standardisation is really interesting, isn't it, with staff moving from one organisation to another to know what they can and can't actually do. We've got 2 minutes left, so I'm going to squeeze in one more question, if that's okay. And it is quite an interesting one. It's about patients in intensive care units, and the question says, patients in ICU suffer most of all from deconditioning, being on ventilators and unconscious. And if not seen regularly by the PT and OT, they quickly lose their muscle tone, and when moved to the wards are more challenging to get them up and moving out of bed. What advice can you give to remind all of us of our responsibilities to prevent deconditioning? Anne-Marie, could I bring you in there?
Yeah, so I think they are a vulnerable group, but the principles are the same for all patients. And it is about making sure that we've assessed, we understand what their needs are, and we've got a really good plan put in place for that. All the other things that we need to do around educational support tools are exactly the same. And again, as I said it in my presentation, if we can't maintain what these patients need, flag it. You know, whether that's a day text or an incident form or a conversation with somebody senior. Flag that we can't do what we want to do to keep these patients as fit and well as they can be and stop them deconditioning more. That in itself will start helping people to get the right action, I think.
That's great. Thank you very, very much. This has been a fantastic hour. It's gone so quickly. And I'd really like to thank Sharon, Julie and Anne-Marie for a really lively discussion. I'm sorry we haven't got to all of the questions, but hopefully we picked up some really key themes about assessment, about confidence, about being curious and asking questions. And I think that last point from Anne-Marie about making sure that if you can't do something, that we flag it and report it is really important. If you'd like to know more about deconditioning, there are lots of resources out there. On our Nursing Times clinical zone, we've just actually launched a deconditioning section where you can get lots of information to support your practice. And this webinar and the downloadable supplement, which Sharon has worked with us on, will be available in the next few days, and both of those resources will be free, so you can share them with your colleagues and get some discussions going in your local organisations, wards and units. Thank you very much to Hillrom for supporting this webinar today and making it possible. And thank you to all of you for joining us and for participating. I mean, you've been fantastic. The chat box has just been full of questions. So thank you all very much, and I hope you all have a fantastic afternoon.
Thank you.
Thank you.
Bye-bye.